Welcome and thanks for joining us for our webinar tonight about HRD testing and how it's different from germline genetic testing. So my name's Robyn and I'm the Programs and Advocacy Manager at PINCOPE. And I would love to start tonight by acknowledging that I come to you from Ngunnawal country here in Canberra. And I'd like to acknowledge and pay respects to elders past, present and emerging. And also acknowledge that everyone listening tonight is coming from different parts of this wonderful country, and I guess just say how lucky we are to be here in Australia. So I wanted to start tonight by just telling you why we organised this webinar. So PINCOPE is a patient support organisation for people with hereditary cancer risk. Many of our community are gene mutation carriers, and many people in our community, they simply have a strong family history of breast, ovarian or prostate cancer. So we organised this webinar because we wanted to ensure that people in the community were aware of the differences between HRD testing and germline genetic testing, which obviously by the end of tonight, I hope you are all very much able to tell the difference between. We also wanted to raise awareness for HRD testing and its importance for ovarian cancer patients. And of course, we as an organisation understand the impact of both germline and tumour testing, and we understand the impact it can have in patients and obviously the flow-on effects for families. So we wanted to hold this webinar to ensure that both patients and health professionals are informed and aware of, the implications and, the differences between those types of tests. And also, of course, we know that clinical information can be quite complex. And we wanted to just make sure that we had experts on hand who were able to, explain those finer details of these two different types of testing. So I want to acknowledge that we can't put on these free education events without support. So I really wanted to say a really big thank you to AstraZeneca and GSK tonight, because those guys have supported us and made this webinar possible. And I also want to thank our wonderful experts who have given their time freely in the name of education. So thank you very much to those on the panel tonight. And of course, Upinder, who is generously sharing her story tonight. And we really value lived experience and know the impact that hearing these stories can have on others. So thank you very much for being here. So I'm going to introduce Heather now, who has the world's longest biography. But we are very grateful to have Heather here to MC tonight. So Associate Professor Heather Thorne, OAM, is the National Manager of kConFab, which brings together geneticists, clinicians, surgeons, genetic counsellors, psychosocial researchers, pathologists and epidemiologists from Australia and New Zealand. Heather has a background in lab research in molecular genetics of breast cancer, and she was appointed in '97 as the first National Manager of kConFab. She has a particular interest in expanding upon a biobank/cohort translational role by supplying participants, their families and their treating family cancer clinics with clinically significant BRCA, P53, PALB2 and ATM mutation test results, and assisting in recruiting eligible participants to new targeted therapies based on their genetic testing profile of either germline or somatic mutation. So as you can hear, Heather is very much qualified to be emceeing this discussion. So I'm going to hand over to Heather. Thank you very much.
Good. Thank you very much, Robyn, for the warm welcome. It's an absolute pleasure to be involved with this seminar series tonight. I'd like to thank you and the PINCOPE team for putting this seminar series on, because it's very important information, as you've already outlined, for the community. And I'm sure the audience online will be very appreciative to hear from our expert speakers this evening. As you said, we have 4 fantastic speakers, of which one of them is you. Our first speaker will be Professor Paul Cohen. Paul is a consultant at the Western Australian Gynaecological Cancer Service, King Edward Memorial Hospital in Perth, a clinical professor in the Division of Obstetrics and Gynaecology, the Medical School, University of Western Australia, an adjunct professor at the Institute for Health Research, University of Notre Dame, Australia. Paul's research interests include patient-reported outcomes and the supportive care of patients affected by gynaecological malignancies, cancer genetics, the epidemiology of gynae cancers, and biomarkers to predict histological tumour regression in women with high-grade serous ovarian cancer following neoadjuvant chemotherapy. Paul's involved in numerous national and international gynae committees that include, he currently chairs the International Gynaecological Cancer Society Education Committee, the Australian and New Zealand Gynae Oncology Group, which is a very large, impressive group, the Research Advisory Committee, and is a board director of ANZOG and IGCS. Our second speaker this evening, we're very lucky to have Upinder, a patient of Paul's. Very fortunate to have her share her patient experience with us. She will outline her family history to us in a little detail, but why Upinder is really important to us tonight is that she's going to talk to us about her experience with HRD tumour tissue testing. She actually doesn't carry a BRCA1 or BRCA2 gene mutation, but due to the HDR tumour testing, she is now also on the pretty wonderful PARP inhibitors that are available for gene carriers these days. So I know everyone's going to be really interested in hearing her personal story. The third speaker tonight is also a very close colleague of mine, Dr. Cathy Kiraly-Borri. Cathy is a senior clinical geneticist, also based in Perth with Paul. She is a seasoned clinician in both the public and private sector, involved in genetics. She has over 20 years of experience in various genetic consultation domains, and her specialisation lies in paediatric oncology, genetics and familial cancer. And then our last speaker this evening is Robyn Smith, who I probably really doesn't need any introduction. As you know, Programs and Advocacy Manager at Pink Hope. We've all worked with Robyn extensively for many years now. Robyn has a background in finance and health promotion and is a keen advocate for patients making informed decisions about managing their cancer risk. She's contributed to numerous research projects focused on women's choices around going flat after a bilateral mastectomy and research investigating adverse events related to breast implants. I know Robyn is fielding questions and answers at the end of the seminar series. So please put any questions that you may have into the chat box. We hope to cover as much as we can, but sometimes your questions are very informative to us as well. So it's with my pleasure now to introduce to you Professor Paul Cohen, who's going to start by providing a background on HRD in ovarian cancer. And when we talk about ovarian cancer, Paul, I'm assuming it's also going to cover fallopian tube and peritoneal cancer as well. You can update us about that and why HRD testing is important. Paul's going to share a screen with us and then we'll come back and ask Paul some questions after his formal presentation. Good, over to you, Paul.
Thank you very much, Heather. And I'd also like to thank Robyn and Sarah from Pink Hope for the invitation to be involved in this evening's webinar. And also special thanks to Upinder for also being involved this evening. So let me just, that's sharing, okay, is it?
Yep.
Great. So I'm based, as Heather said, in Perth in Western Australia at King Edward Memorial Hospital. That's a nice WA sunset. And there we go. So I'm going to cover a bit about what HRD is, how we test for it, how testing for HRD differs from germline genetic testing, but Cathy will talk in a bit more detail about that as well. And then focus a little bit on why it's important to test for HRD in ovarian cancer, and then some specifics about who we test, what we actually test, and when we test, And if there's time, very happy to take some questions at the end. So what is HRD? Well, HRD stands for homologous recombination repair deficiency, or HRR deficiency. And what is HRR? HRR is basically a DNA damage repair mechanism, which is very important. I think I'm just going to take a little step back and try and cover some very basic biology, which I'm sure many of you will know. But as you'll appreciate, every tissue in the body is basically made up of cells. And we see here a cell, and a cell is made up of a nucleus and some other fluid around the nucleus. The nucleus is very important because it contains our genetic material. And the genetic material is basically packaged into chromosomes, which is this structure that we see here. And the chromosome basically contains our DNA, which is the double helical structure here. And DNA basically contains all of our genetic material. So I'm going to just go through some very quick definitions. We'll talk about what a gene is in a moment, but we're very guilty in medicine of using multiple terms to mean the same thing, and I think this is quite confusing to people. So the word gene mutation is exactly the same as a gene fault or a gene abnormality or a gene pathogenic variant, and really the preferred terminology is gene pathogenic variant or gene variant, which causes a disease. They all mean the same thing. Also the term wild type, which you may hear, which basically means the usual form of a gene or a normal gene. So just a little bit about what a gene is. A gene, very simply, is the basic unit of heredity. And it's essentially just a sequence of molecules or a sequence of DNA made up of 4 different substances called nucleotides. And they all have letters. And that's basically our genetic code. It's made up of 4 different letters. And you'll see on the right-hand side of this diagram that the code there has 1 letter different. So in the middle, you can see TGA, and then if you look at the line below, there's a C instead of a G, which is basically a substitution. And if we have that, that's a variant which can cause disease because the protein or molecule which the gene actually builds or codes for doesn't get made. And that can cause disease. So this diagram is just to remind me to say that our DNA is constantly being exposed to errors. So we're continually getting damage of our DNA in all the cells in our body. And that damage can be caused by ultraviolet light, by smoking, by chemicals in the environment. And it can also be damaged as our DNA divides. We're made up of trillions and trillions of cells, and these cells in many tissues, for example, our lungs, our gut, our ovaries, are continually dividing to make new cells. And in that process of division, the DNA has to replicate, and it's very, very prone to errors or mistakes as it replicates. And so there's multiple sources of damage to DNA, and we have multiple different mechanisms to repair that damage. So I just want to highlight a couple of mechanisms. DNA, as we see here in the box on the left, can have single strand breaks. As we've said, DNA is basically made up of 2 helices and individual spirals. So you can get a break in 1 strand, and that's repaired by, or you can get a break in 2 strands. What DSB stands for double strand break. And the single strand break is repaired by an enzyme called PARP, poly-ADP ribose polymerase. That plays a key role in repairing single strand breaks. And double strand breaks are repaired by 2 mechanisms. HR stands for homologous recombination repair, HR, and NHEJ is non-homologous end joining, which is slightly less important. So key mechanism of double strand break repair is homologous repair. And I just want to talk a little bit about a concept called synthetic lethality, because this is very important to understand when we come on to speak about PARP inhibitors in a moment. So you'll see at the top here a single strand break in DNA. The green strand of DNA is split. And in the bottom, we've got a double strand break. So both the purple strand and the green strand have been fractured. And in normal cells, the double strand breaks are repaired, as we've said, by homologous recombination repair. and the single strand breaks are repaired by PARP. So if we have a BRCA mutation either in all the cells of our body, which is what we call a germline mutation, or in cancer cells, only in the cancer cell, we don't get double-strand DNA repair. We're not able to repair breaks in DNA, which are double-strand breaks. If we then poison PARP by using a PARP inhibitor, we take out the only mechanism we have for single-strand DNA repair, and that leads to the death of the tumor cell. So this is the concept of synthetic lethality. Another way of explaining this or describing this is a four-legged table. Having different mechanisms to repair DNA is basically an insurance or what we call built-in redundancy. So if we have lightning striking one leg of the table, and let's say that leg of the table is single-strand DNA repair in a cell, the table still stands because it can stand on three legs. If we have a lightning strike of the same leg of the table, so let's say we take out single-strand DNA repair by inhibiting PARP, and then we have a second lightning strike which takes out our ability to repair double-strand DNA breaks by homologous recombination, then the table doesn't stand and it falls over, which is the same thing as the cell dying. That's, again, synthetic lethality. So PARP inhibitors are a relatively new class of drug. As we've said, they inhibit the action of the enzyme PARP, which, as we've said, is a key enzyme involved in single-strand DNA repair. So if we block PARP, we prevent single-strand DNA repair. We have two PARP inhibitors approved for use in Australia, olaparib or Lynparza as its brand name, and niraparib or Zejula. And these are tablets taken by mouth. They're not chemotherapy. They're what we call targeted therapies, and they're usually used as maintenance therapy. So this is treatment that comes in a few weeks after chemotherapy. So I want to talk a little bit about HRD testing now and what we're actually testing for. So we can test for the cause of homologous repair deficiency, or we can test for the consequences of homologous repair deficiency, or we can test for a combination of both. And actually in practice, we test for a combination of both. So this diagram, I don't want to spend too long talking about, it's quite complicated, but it's a pie chart which demonstrates genes which are implicated in the cause of the most common type of ovarian cancer, which is called high-grade serous cancer. Now, when I use the term ovarian cancer, and Heather alluded to this just before my talk, I'm also referring to fallopian tube cancer and a cancer which is called primary peritoneal cancer. They're really all one and the same thing when we talk about high-grade serous cancer. So high-grade serous cancer can pretty much be divided in two. The right-hand side of this pie chart shows a series of genetic changes which are responsible for homologous repair deficiency. And the genes within this top part of the pie chart are essentially changes in or variants in BRCA1 and BRCA2. And in the bottom half, we have other genes which are also important in homologous recombination repair. And if you have variants in some of these genes, you can get homologous repair deficiency. This is a diagram which just demonstrates the consequences of homologous repair deficiency. So other things that we test for. And these are essentially, when you have HRD or homologous repair deficiency, you get what's called genomic scarring. So permanent changes in the genome. The genome just means all the genetic material that we have in our cells. And there are a few different changes that you can get. On the left-hand side, we see something called loss of heterozygosity. So this is where a section of a gene or an entire gene is lost. And we lose one of two copies of a gene that we have. We all have two copies of a gene. One we inherit from our father, one from our mother. And if we lose one of these copies, we have what's called loss of heterozygosity. If we lose genetic material at the very end of a chromosome, the end of a chromosome is called a telomere. Telomeres are implicated in aging. This is called telomeric allelic imbalance. And finally, we can get very large changes in genes or a whole series of genes, which are called large-scale transitions. And all of these are essentially scars in the genome which result from homologous repair deficiency. So what do we test when we do homologous repair deficiency testing? We have to test tumor tissue ideally, or it's tissue testing. There are many different testing platforms. One of the original platforms was produced by a company called Myriad. It's called Myriad My Choice. Foundation One is another one of the early tests. Sophia is another platform, but there are many, many platforms and more coming online with every month. It's very important that the laboratory doing the testing is accredited, and in Australia we have the National Association of Testing Authorities, or NATA, which accredit laboratories to do this testing. And HRD testing is different to germline genetic testing. So just a little bit about the difference between germline and somatic variants or tumor variants. Germline variants are variants or mutations in genes which are either in sperm or in an egg, which as we develop as embryos then are passed on to every cell in our bodies. And these are inherited, and we test for them commonly either using blood or saliva. Whereas somatic variants are variants or mutations which only occur in a particular tissue or cancer. And we test for these in the tumor. In ovarian cancer, overall, about 15% of ovarian cancers have germline variants in BRCA1 or BRCA2, and another 5 to 7% have variants in BRCA1 and BRCA2, which are only in the tumor, so what we call somatic or tumor-only variants. So overall, about 20% of ovarian cancers have BRCA1 and 2 variants, either in the blood, germline, or in the tumor. Just a little bit about how we look after patients with ovarian cancer, and particularly referring now to advanced stages, so it's what we call stage 3 or stage 4. Conventionally, it would always be an upfront operation, a surgery to remove all of the cancer, followed by 6 cycles of chemotherapy, usually a combination of 2 drugs, carboplatin and paclitaxel, given as what we call cycles. Each cycle lasts 3 weeks, so about 4.5 months of treatment. In recent years, there's been a big uptake of what's called neoadjuvant chemotherapy, so giving some of the chemo before surgery, then what we call interval surgery, and then more chemotherapy following the surgery. Occasionally, patients, and this doesn't happen very commonly, would receive all the cycles of chemotherapy up front, and then they may or may not have an operation depending on their response. But this is not common. It's a small minority of patients. Majority of patients in Australia and worldwide would be treated by one of the upper treatment pathways. Following completion of treatment, most patients now in Australia would be on some sort of maintenance therapy. And maintenance therapy can either be an intravenous medication called bevacizumab or Avastin, or one of the 2 PARP inhibitors, and sometimes both. So just to summarize the current first-line maintenance therapy in Australia, on the left-hand column, we have what we call the biomarker, so the variant or mutation, which basically predicts how somebody might respond to the treatment. And so if you have a germline or tumor-only variant in BRCA1 or 2, the maintenance therapy options would be olaparib only, olaparib plus bevacizumab, or niraparib. If you have no BRCA variant, but your tumor is tested and you're found to carry, the tumor is found to be homologous recombination repair deficient, or HRD, then the options would be either olaparib and bevacizumab or niraparib. If your tumor does not carry a homologous recombination repair deficiency, in other words, it's HR proficient, and you don't have a BRCA mutation in your germline, then the maintenance therapy option would be bevacizumab for certain indications, usually if you have bulky residual disease after your surgery, or if you have stage 4 disease. I just wanted to cover, before I finish, a couple of the key trials which led to the approvals of these medications. The first trial, which was really a very, very important trial, was called SOLO-1. And SOLO-1 was published in 2018. And this is the design of SOLO-1. So basically, SOLO-1 only enrolled patients with ovarian cancer, high-grade serous ovarian cancer, who had either a germline or a tumor BRCA mutation, BRCA1 and BRCA2. So to be eligible to get into this trial, you had to have a BRCA mutation either in your tumor or in your germline. And patients were randomized to receive olaparib, which was, as I say, as a tablet taken twice daily, or to a placebo. And the primary endpoint of the study was what we call progression-free survival. So how long were patients in remission? And this was the main result that was published in the original paper, which really showed that at 3 years after being on the medication, 60% of people who were randomized to the medication still were in remission, compared to just under 27% of patients who were in the placebo. And this led to the approval of olaparib in Australia and worldwide for patients who had ovarian cancer that had either BRCA1 or BRCA2 in their germline or in their tumour. Second study I just briefly want to mention is called the PRIMA study. This was also published in the New England Journal in 2019. And this was a study that did not just enroll people with BRCA1 or BRCA2 variants. It enrolled all patients with stage 3 or stage 4 ovarian cancer. And they were randomized to niraparib or to a placebo. And the primary endpoint again was progression-free survival. And this was the headline result in patients who had HRD, so whose tumors were either BRCA1 or BRCA2 or normal BRCA1, BRCA2, but homologous repair deficient. And really you can see that if you had homologous repair deficient tumor and you were randomized to niraparib, you had a 50% lower risk of progression compared to patients who were on the placebo. This was the same trial. This was PRIMA, but this was all patients. So this was patients with HRD tumors and HR proficient tumors. And overall, there was a 38% lower risk of progression for patients randomized to niraparib. But importantly, when they looked at the HR proficient subgroup, so these were patients whose tumors were HR proficient, there was also a benefit, although lower than the benefit if your tumor was HRD, of about 32% lower risk of progression. And the final study I want to talk about is called PAOLA-1, which was published just a little bit after PRIMA. And this trial was looking at a combination of olaparib with bevacizumab. And again, these patients did not just have BRCA1 and BRCA2. This was all patients with stage 3 and stage 4 high-grade serous or endometrioid ovarian cancer, including fallopian tube and primary peritoneal. Patients were randomized to receive olaparib, which they took for 2 years, plus bevacizumab, or to placebo plus bevacizumab. And again, the primary endpoint of the trial was progression-free survival. And this was the headline result. So patients who had HRD tumors, and this included patients with BRCA variants, had overall a 67% lower risk of progression if they were randomized to olaparib and bevacizumab compared to those patients who were on placebo plus bevacizumab. These were patients whose tumors were homologous repair deficient but did not have a BRCA mutation. And again, a very significant benefit of 57% lower risk of progression if you had an HRD tumor without a BRCA mutation, but you were randomized to olaparib and bevacizumab compared to patients on placebo. Importantly, when they looked at the patients whose tumors were HR proficient, there was no benefit of olaparib and bevacizumab. The hazard ratio was 1, which basically means there was an equivalent progression-free survival between patients on the olaparib and bevacizumab and patients on bevacizumab only. So this led to the approval of olaparib with bevacizumab for patients whose tumors were HRD and not HR proficient. So just a final couple of slides now. Who should we test? Well, current guidelines recommend testing for HRD in addition to BRCA testing for all patients with newly diagnosed advanced ovarian, fallopian tube, or primary peritoneal cancer. And as of January this year, HRD testing is available through the MBS. When should we test? We should test as early as possible after diagnosis. We test only patients with high-grade epithelial non-mucinous ovarian, fallopian tube, or peritoneal cancers, because these are the cancers in which HRD has been found. There are other subtypes of ovarian cancer where HRD has not been found, and so and also in which PARP inhibitors have not been tested. So this is the indication, really. So any high-grade advanced stage cancer which is not mucinous. and not low grade. And if we test early on, ideally as soon after diagnosis, this allows for adequate time to receive a result, because results can often take about 6 weeks, sometimes a little bit longer. And then we get the result back before completion of chemotherapy. And this guides further treatment. In other words, will the patient or may the patient respond to a PARP inhibitor? What tissue should we be testing? So ideally, and I've done this in the order that is preferable, but in reality, it's not always possible to do this. So ideally, we want tissue that's not exposed to chemotherapy. So before any chemo is given, and I'll explain the reasons for that in a moment, but we test tissue either from laparoscopic biopsies. If we're not able to get laparoscopic biopsies, then the next best thing is to get a core biopsy that's usually done under a CT or an ultrasound. And ideally, we want a minimum of 2 biopsies, ideally 4. Or if the patient's having primary surgery up front without biopsies, because there's a strong suspicion of ovarian cancer, then we use that tissue to do testing. Now, interval surgery is not ideal. And that's because patients, as I said, in that management diagram flowchart, will have had 3 or 4 cycles of chemotherapy. And it's not ideal, because if patients respond very well to that chemotherapy, then the tumor tissue that we remove at surgery may not have very much viable tumor cells and not enough for testing. The other thing is that the DNA undergoes changes when it's exposed to chemotherapy, and often the test will fail quality control. So there's a high chance, if that's the only tissue we have, that we may not be able to get an HRD result because the tissue is not high enough quality. But if we don't have any other tissue, then we send interval surgery tissue. The other thing at the moment that is sometimes possible if there's no other tissue is acidic fluid. So this is a buildup of fluid, which can be quite common at ovarian cancer diagnosis. And if there's enough cells in that fluid and we don't have any other tissue biopsies, we can sometimes get a result from that. But that's also not ideal and not the preferred way. It's also very important, I've highlighted this in the bullet point at the bottom, that we don't forget about germline testing. So we have to do both. So we test germline testing for BRCA1 and BRCA2 and some other genes which can cause ovarian cancer and which are hereditary, but also testing for HRD. This is an excellent guideline which was published by Ovarian Cancer Australia towards the end of last year about optimal tumour tissue collection, and accepting that practice varies around the country, and sometimes people will be seen first by a medical oncology specialist, and all patients are usually discussed at a multidisciplinary meeting, and just depending on what the recommendation of that multidisciplinary meeting is as to whether patients will have chemo first and then surgery, or surgery first, may dictate what tissue is available for testing. But everybody should have HRD testing. And this is an excellent guideline. And this is a colleague of ours, Professor Orla McNally, who's on the front cover. And she said, HRD testing is a game changer for women with ovarian cancer, and it's great to see it becoming standard of care. So concluding remarks, this is my last slide. HRD testing provides very important information for clinicians to guide treatment. It allows a more personalized treatment approach, but there are some challenges associated with HRD testing that relate to the test itself, the timing of testing, and obtaining an adequate amount of tissue to do the test. Research is ongoing currently to improve HRD testing. In fact, there was a presentation at a recent conference in the US about artificial intelligence and using AI on standard histopathology slides, seemingly as accurate or even more accurate than the current test that we use. So I'm sure in time, HRD testing will become much quicker, more sophisticated, and even more accurate. My final comment is that the pie chart which I showed you, 50% of patients have tumours which are HR proficient, and we need much more effective treatments for these patients. And that's the end of my slide. So thank you very much. And as I say, very happy to take questions.
Good. Thank you very much, Paul. That was really informative. And you've really showed the importance there. Well, 2 important things, I think, that the difference between the tumour tissue testing versus the germline blood testing? Because when we talk about genetic testing, I know the patients can become very confused about tumour tissue versus blood and inherited. So, and I know Cathy's going to go into that a little bit further. But certainly you've highlighted too the advantages in having genetic testing done, so that you can get access to these new generation targeted therapies that, you know, let's hope as time goes on is really improving the patient outcome for ovarian cancer patients. Paul, just a few practical questions from me. So at this point in time, how often is HRD testing being done clinically? Is it really being done only in the NATA-accredited large academic hospitals in each state and territory, or is it becoming fairly universally available even in, I'm not saying remote, but you know, reasonably large regional centres?
Thanks, Heather. So look, I mean, HRD testing absolutely should be standard of care and should be discussed at multidisciplinary team meetings and requested by the specialist providers who are looking after patients. Now, what's happening in reality, I can only speak to our own centre in Western Australia. And look, accepting that, you know, there's always a slight lag when new technology is introduced and clinical trials are published and guidelines are published, you know, between that and then, you know, uptake as the standard. So there are always delays there. And I think this is one of the reasons for this webinar that, you know, patients should really be questioning their specialists and asking, has the testing been done? So, so it should be being done. I know it's something the National Gynaecological Oncology Registry is now going to include as a key clinical quality indicator. So that's going to be audited. And we need, you know, clearly HRD testing, it's not even 12 months. I think it was July last year that testing became widely available, initially as an access program before the MBS item number was approved earlier this year. So to answer your second part of that question, the testing should only be being done in a NATA accredited laboratory. And I know there's a drive, I think all states are working on that. We've in Western Australia only recently, our main molecular pathology provider has got NATA accredited. Initially, when this started, I think the idea was that all specimens would be done centrally at the Peter MacCallum, because they were one of the only labs that actually had accreditation. But you know, I think more and more laboratories are being accredited. But and in fact, if a provider is looking after somebody in let's say a regional centre were to request it, technically if a laboratory is not accredited, they're probably not doing it, and so they would send the request back or pass it on to a lab that was accredited.
So I suppose anyone on any of our audience on the webinar tonight, either personally or with a family history, ovarian cancer diagnosed, not getting perhaps a definitive answer from their treating doctors, a second opinion's never a bad idea from perhaps a larger city centre.
We've had a question, Heather, actually, from one of our audience about if you've had a stage 4 ovarian cancer and you're in remission, if you have a recurrence, can testing be done? And that's a really good question and a very important question. And the answer to that is yes and no. So HRD testing, no. But tumour BRCA testing, if it wasn't done first time round, yes. Because PARP inhibitors are approved for patients who have not had them as part of first-line maintenance therapy, but who have a relapse where they've relapsed sometime after completing treatment. So for what's called platinum-sensitive ovarian cancer. So if you have if you've had a platinum-sensitive ovarian cancer, you are retreated with platinum and you respond. And you've got either a germline BRCA 1 or 2 variant or a variant of BRCA 1 or 2 in your tumor, then you would be eligible for a PARP inhibitor. But HRD testing, which is, as we've said, slightly different, not at recurrence.
Good.
Heather, can I jump in? I just wondered if you wanted to go to Upinder, because I know she's got some family commitments. And I wondered if you wanted to throw to her.
Certainly. Thank you, Upinder. Thank you for giving your time and being willing to share your experience tonight. Would you like to give a very brief update just to start about your family history? Was there history of cancer in the family? What your symptoms and how the diagnosis came about?
Hello.
Yes.
Hello. Yeah, can you hear me? Oh, yes,
Good.
yes. Thank you so much, first of all, giving me an opportunity to, be a part of this wonderful meeting and share my experience. Well, luckily, my family don't have any history of the cancer. So I am the first one that had ovarian cancer. And unfortunately, I got to know when it was in stage 3. So I've been struggling with my weight gain from a couple of weeks, you can say a couple of months, maybe last 2 years after the COVID hit Western Australia. But I don't know, suddenly it's been a year now, this June, it's been a year that I've been going to the doctors and getting my, checkups done. So I just had a pain in my lower stomach. And continuously, I had a pain for 3 days. And when I had my ultrasound done, then I got to know that I have cyst. But after I had my blood test done for the cancer one, then my cancer cells were 766 instead of, it was above the limit. So then I got to know that it's not only the cyst, but it is a cancer. So then it was my gynecologist referred me to Dr. Raj Mohan, who did my surgery. And then I had done laparoscopy before because they couldn't find the source of the cancer, because the cancer cell was in my liver, in my bowel, and definitely it was in the ovaries as well. But after laparoscopy, I got to know that it is the ovarian cancer. Then exactly I got to know in last year, October, that it was a high-grade serious cancer. And I had to go for the surgery. And then I had 6 chemos, which were last chemo finished on 5th of April. And now I'm on the medication, as just Dr. Paul mentioned it in the slides. The lepro one, what was it? I don't know the name. So it's still going on, but luckily I'm having another surgery now to get rid of my stoma bag on 3rd of July. So I looking forward that once I get rid of my stoma bag, then I can get back to my normal life and I can do the other things. I want to learn swimming, but I was worried with my stoma bag that, it's not, I'm not comfortable with that. So hope so it will not go further in my family, because that's what I'm worried, because it's not only me, I have my siblings as well and my cousins. So we have a huge family. And then I really want to make sure that it's just stop here with me and doesn't go in my kids.
So I guess I have a 2-pronged question here. With no family history of breast or ovarian cancer, I suppose the diagnosis at your young age came completely out of left field. So that was the first big shock. But then with no family history, you probably didn't have much understanding about genetic testing, which I assume you underwent both blood, and we know that you had the HRD testing, but that must have been really confronting, dealing with a diagnosis, but then trying to get your head around that whole genetic testing area as well. Was there anything that helped you navigate that process?
Oh, well, we didn't know that we had to go for the genetic testing. It was the doctors that recommend us, because since it was in an advanced stage, they they really want to make sure, because they were doing their part the best, because they have seen so many families, and when they know that none of my family member had this cancer, how can I have? So that's why they recommend us to go for the genetic testing. It was a big shock. It is a big shock today as well. When I think of it, close my eyes, think how many chemos I have been through, the surgery, because the person who is suffering from cancer is not the only one who is going through, the mental trauma or emotional trauma or the physical trauma. All the entire family members, wherever you live, like I live in Australia, our family is in India. So everywhere, everybody has to go to, the mental trauma, because even especially with the kids, the young kids. My kids got to know in January after I had my, I think, first chemo, that yes, I've been through, the cancer, I had my surgery. So it is a tough thing. So it is a trauma for everyone who is related to you, your family member, your friends, even your colleagues, everywhere. Everybody was in shock, apart from you as well. So I hope it's getting better now.
And so with the HRD testing, how did that impact your treatment?
Well, I just want to make sure that it's, it doesn't go further after, this medication. Because when I got to know about that this medication is going to help me for another 2 years, I just want to make sure that if in case if I get diagnosed with the cancer again, which part of my body will affect now. So it was the abdomen, in case if I get it. So fingers crossed. So that's another thing I want to make sure, that if all the test goes correct, if it is negative, that is not going in my genes, it's not going to affect internal organs of for myself or my kids, then I think I'm happy to go with the medication for, couple of years, until and unless it's gone all from my body. I hope that answers your question.
No, good, thank you. And so what advice, unfortunately, having gone through this process, what advice would you give to a young lady these days who's just been diagnosed with ovarian cancer, who's been offered the HRD test?
The advice is, just don't lose hope. Don't lose hope, because if it is for your benefit, these tests are for your benefit. It will tell you whether it is growing further in your family or not, because if it doesn't stop in you, it's going in your kids. You have to be very, very careful, because nobody was there when I was diagnosed with the cancer to tell me, oh, if I'm getting my stomach pain, I should be going to the doctor, because every time I was ignoring my stomach pain, just saying it's a normal period pain. So this is the problem. We always ignore, all the ladies, I think all the young girls also, oh yes, it's a period pain, it will go away, taking one Panadol. But one Panadol is not going to treat the cancer. So all I suggest to whosoever is suffering from this one, please don't lose hope. You need to be mentally very, very strong, and always, remember God in your prayers. So that's what I will say. So thank you so much for giving me an opportunity to be the part of your, the wonderful meeting in here. And I also got to know so many things which I was not aware of. But thank you so much.
Yeah. Well, thank you very much for sharing your experience. We don't often have, patient involvement in these seminars, but as I said, I'm sure anyone listening in today, everyone will be gaining benefit from your personal experience. So we really appreciate you taking the time.
Thanks so much, Upinder.
Yeah. Now, do we have another question for...
Yeah, we do. There was someone in the Q&A. I think this one might be for Paul, probably. It says, this is from Tony. Hello, and thank you. She's asking if you had genetic testing after a diagnosis, and it was an incidental finding after a hysterectomy, and there were no mutations, would it be useful to obtain the somatic testing results of the tumour in case of future recurrence?
Yes, it would. Yes, it would. And I say that because sometimes at recurrence, it's not always possible to get a tissue biopsy of adequate size to test, and so I think any information that can be gained is very helpful information. So I think if that's an option, I would recommend that.
Great, and I've got Kristen who has raised her hand, but Kristen, can you just type your question, just because we can't unmute everybody on this webinar, so if you can type it, that would be great. And someone else just raised their hand briefly, but if you can type your question, we can read it out.
Paul, I have one more question, and I'm going a little bit off script here, but in BRCA1 and BRCA2 germline, or so inherited mutation carriers with breast cancer, we're now seeing recently PARP inhibitors being used as frontline treatment, no chemotherapy. Very early days, and I'm seeing it at Peter Mac with the patients that we have there. Is there any thought in this being done with ovarian cancer, perhaps for the ones with stage 1 and 2 at diagnosis, rather than stage 3 and 4, more the advanced ones? Or is it still not being considered at the moment?
But that's a very, very good question, Heather. I think if I can answer it in two parts, we only have data in ovarian cancer about the effectiveness of PARP inhibitors in advanced disease, so stage 3 and stage 4. None of the trials recruited patients with early stage. And the reason, I think, or part of the reason for that is that stage 1 and stage 2 have a much, much better long-term prognosis. And PARP inhibitors are not without side effects. And potential serious side effects, although generally I have to say they're very well tolerated. Tablets and most of the side effects are very manageable. So I think for stage 1 and stage 2, there's no trials proposed at the moment. For stage 3 and 4, I thought you were going to say, is there any interest in using PARP inhibitors only instead of chemotherapy, similar to breast cancer? And I think the thing to say there is they're very, very different diseases, particularly in terms of the volume of tumour. So with breast cancer, you're talking about obviously much, much smaller tumours, whereas with ovarian cancer, as you know, at advanced stage particularly, there's a lot more volume of tumour that one needs to treat. There is interest now in looking at PARP inhibitors as part of neoadjuvant treatment, so giving them with chemotherapy, and there are trials in the planning stages. The other thing which you may be aware of, and I'm not sure whether there have been any developments, but there's some interest in perhaps looking at a low dose of a PARP inhibitor for prevention. But fraught with some issues, I think, in terms of practicality. So this would be for women who carry a germline BRCA1 or BRCA2 variant who are having risk reduction surgery, where there's the precursor to high-grade serous cancer is in the fallopian tube. So there's a pre-malignant or potentially pre-malignant change that happens at the ends of the fallopian tube. And sometimes, rarely, it's not very commonly, but a very small proportion of patients who have risk-reducing surgery because they know they carry a BRCA1 or BRCA2 variant, and they've completed their families, and at the recommended age, undergo surgery to remove their ovaries and fallopian tubes. when we find these pre-malignant changes in the tube, it was discovered a couple of years ago that there is a substantially higher risk of subsequent peritoneal cancer. Even though the ovaries and tubes are removed, in the next decade, a number of women will go on to develop high-grade serous cancer of the peritoneal lining. And so there's interest in perhaps using a PARP inhibitor for a shorter time, maybe 12 months instead of 2 years or 3 years, as a chemo prevention strategy. But I think the practicalities of doing that trial are challenging, and that may come in the future.
Yes, I know we've been part of those discussions, and yes, some of the logistics. The use of preventive medication has a very poor uptake. So in breast cancer, for prevention of breast cancer. So yeah, there's many other issues at play there. Good. Well, we might. Oh, do we have a question, Robyn, typed in? Not yet. Okay. Well, look, still time to write your question into the Q&A box. So, Paul, look, thank you very much. You've explained HRD testing, the difference between the tumour tissue, which is somatic testing, versus the germline blood genetic testing. We might move on to Cathy now, who's going to explain this in a little bit more detail. And Cathy, I believe you are also going to share your screen and you have a presentation.
Unmute yourself, Cathy.
Sorry, can everyone see that? The slides? Yeah, okay. And I'm sorry, that's actually repeating what Paul really comprehensively explained, but just a few reminder about body. We've got thousands and thousands of cells in our body, and inside these cells, we've got something that's called chromosomes that are like bottles that contain our genes. And we've got also thousands of different genes, and each of these genes is a little bit like an instruction manual that tell the body what to do. And some of these instruction manual is actually about protecting the body from cancer. And that's just to explain what happens when cancer develop. With age, diet, environment, and all sorts of things that Paul mentioned before, we can sometimes accumulate gene mistake in our cells. And with the accumulation of these gene changes in a cell, suddenly the cells start dividing without control. And that's what we call a tumor. So really, when we are talking about HRD testing, what we'll be testing is that tumor. So things that have been accumulated over time. Whereas when we're talking about germline testing, when we're using, for example, a blood test or a saliva sample, we're actually looking at genes that were present from the time, we were conceived. So that's really what we call germline testing. And just to explain to you why it is important actually to differentiate when, for example, a BRCA gene change is present only in the tumor, or if it's present in all the cells of the body, something that we call germline. So when someone develops a cancer there, because there is an accumulation of gene mistake over time, the gene changes are really present in the tumor only, and we use the word somatic acquired gene mistakes, and they're not elsewhere in the body. So generally, when that's what happens, there is not necessarily an increased risk of developing a new primary cancer, and there is generally limited implication for other relatives. In other words, other relatives do not need to be tested for what's found in the tumor, okay? Whereas if, for example, when we do the germline testing, so when we do the blood test and we find that there is a gene change that's present in all cells of the body, so that was, present even before the cancer started to develop, that's what we call a hereditary cancer, or saying that the gene change is present in all the cells of the body. And what it means is that if someone already has a gene change in all the cells of the body, it may take less time to accumulate other gene changes, and they can develop another cancer. And you know, Heather and Paul were talking about a higher chance, for example, of breast cancer for someone who has a BRCA gene change. And that's important to identify because there are surveillance and risk management options. The other really important thing about hereditary cancer predisposition is that they can either have been inherited or they can be passed on. So other family members can have what we call cascade testing or predictive genetic testing, where they can be checked to see if they've got that exact gene variant. I'm just going to stop there because I think my next slide was really to say what Paul has really extremely well explained about the HRD, which is a features of the tumor that can have different cause, and the different cause can be either that there is a BRCA gene change, which can be present only in the tumor or can be present in all the cells of the body. They can be changed in other genes, and sometimes we don't know what causes. But the effect that Paul mentioned is that genomic instability or the genomic scar, and that's something, again, you can look for in the tumor only. And since I'm just doing that, I might just finish with that. Just about the HRD testing and the Germline testing. When we do HRD testing for ovarian cancer, so again, high-grade serous ovarian cancer, probably about 50% of time, the HRD is not detected. And that's, again, showing the same figure that Paul showed us before. And in 50% of the time, HRD is detected. But there can be different reasons for the HRD. About probably 15% of women have HRD in their tumor because they have what we call a germline genetic variant in the BRCA gene. About probably 10% only have a BRCA1 in the tumor, not something that's present in all the cells of their body. And for another probably a quarter here, we don't find the cause of HRD. So really that's to illustrate that HRD can be associated with different causes. Some of them are present in all the cells of the body, so germline, and some of them are actually present only in the cells. And sorry, I'm just going to stop sharing now. I can go on my screen. Have I stopped sharing now? Is it still sharing? Sorry, I'm just gonna. There.
That's okay.
That's good.
Yeah, I think you were the last one with the slides anyway. Thank you, Cathy, for explaining a little bit further. So just clarifying that the HRD tumour tissue testing doesn't have the opportunity for management of risk like a blood genetic testing result might do. It really has the main function or utility for treatment options.
That's exactly right. So the HRD testing is about managing that tumor and see whether these PARP inhibitor would be helpful. But it doesn't tell us, you know, about, for example, a genetic, an inherited or a gene change that's present in all the cells of the body, which is why, as Paul alluded to, you should do actually both, not just HRD testing, but combine that with what we call the germline, so the blood test.
Good, great.
Heather, can I jump in and ask a question, very unscripted here? As an example, so different to Upinder. So my mum actually had ovarian cancer, and because we had family history of breast as well, she had a germline test. So, and it came up that she carried a BRCA2 gene mutation. And so can you tell me now, if someone came into your office and had a family history, it would be both, or would you just germline test, or would it be an HRD test that would show somatic and then potentially germline?
So it really depends on the situation. If, for example, someone has a family history but comes because they've been diagnosed with ovarian cancer, you would absolutely do both. Okay. And if a germline gene change is identified, it then means that other family members can be tested for that specific gene change.
Yeah.
Could I just add, so in that situation that you just described, if a germline variant is found in BRCA 1 or 2, by definition, the patient's tumour is homologous repair deficient.
Yeah.
Which is a little bit confusing, but so you can have tumours which are homologous repair deficient because of a germline BRCA 1 or 2 variant, or because of a tumour-only BRCA 1 or 2 variant. And as Cathy showed in one of her slides, you can have an HR deficient tumour that is not because of a BRCA1. BRCA1 or 2 can be normal or wild type.
This is exactly why we're having these sorts of webinars to get to the bottom of things like this. So thanks, Paul. Yeah. And Heather, there is another question here. An anonymous person has just asked, does there come a time when the PARP inhibitor becomes ineffective and the cancer outsmarts it? Also, does being on a PARP inhibitor impact future recurrence chemo treatment options?
That's an absolutely fantastic question. So the answer is really what you're getting at there is about something called PARP inhibitor therapy resistance. And the positive thing to say is that there's been the slide I showed you about the first trial of Solo 1, where 60% of patients were progression-free at 3 years. There's been longer term follow-up of that trial reported about a year ago, out to 7 years, and that benefit still persists. About 50% of patients on the PARP inhibitor were still in remission. But obviously the flip side of that is that there are a proportion of women on a PARP inhibitor who do unfortunately relapse. And there's a lot of research going on at the moment into, we understand some of the mechanisms as to why the tumor outsmarts the PARP and the person has a recurrence. But looking at ways of overcoming those resistance mechanisms so that the PARP can become effective. And the other part of the question, I think, was around, was it retreatment?
Does it, being on a PARP, impact future recurrence chemo treatment options?
Yeah, so the answer to that is the short answer is it doesn't impact the chemotherapy choices, and they'll be very much guided by the time from finishing the first chemotherapy. If there's been a decent amount of time from somebody finishing their chemo, being on a PARP, and then having a recurrence, there are evidence-based chemotherapy medications that are used in the second line. Whether it would then be appropriate to retreat somebody with a PARP inhibitor after second-line chemotherapy, there's been a couple of trials looking at that, and there seems to be a small benefit, although the benefit is quite small. So that is not yet standard practice in Australia to retreat with a PARP inhibitor again.
And there's Linnell, you've got your hand up. Can you just type your question into the Q&A if you can, because we can't enable people to actually ask questions. Sorry.
If I can just add also to that question and following on from Paul's answer, certainly within our kConFab research group, and also the Australian Ovarian Cancer Study. We're housed in the same research department in Melbourne, but working with surgeons like Paul and breast surgeons and medical oncologists. We've recruited thousands of patients Australia-wide over 20 years. A big part of our program is collecting ongoing blood samples and tissue samples through a patient's journey, for exactly that reason, that for patients that then fail, let's say, a PARP inhibitor, we then obtain a small amount of tissue, and there's a massive research program going on. What's the next target that's needed to be an effective treatment? So, yes, that's a huge, very boutique, but a huge part of both kConFab and AOCS research work that's happening. Good. Robyn, do we have another type question there?
No, no.
No, that's okay. So, Cathy, just back to another very practical question. So, in the big picture, a patient has come and seen Paul. Paul's done the HRD and germline testing. For ongoing, and let's just say a BRCA1 or BRCA2 pathogenic mutation has been detected in that woman, is that woman automatically referred to the genetics clinic these days, or is it just as common maybe for Paul and or his medical oncology team to manage that patient and then the extended family for what you described as cascade testing, that is genetic testing in all other family members to see if they carry the gene mutation or not? How's the practical aspect? Because we've discovered a lot of genes associated with cancer now, and I know the clinics are getting very full.
They are. And again, generally when we are talking about cascade testing, this is usually done through a genetic clinic. So certainly what we would encourage people who are found to have a BRCA gene variant, even if it's done through what we call mainstream testing, when it's the oncologist or a specialized nurse who does the testing, would be to refer absolutely these families to genetic services, so cascade testing can be offered to other family members.
Good.
Heather, just to pick up on that, I mean, I don't know how it works in Melbourne, but when medical oncologists or a member of the surgical team or our clinical nurse consultants order the test, so this is for germline testing, I would get into major trouble with Cathy if that patient had a germline BRCA1 or 2 variant and I didn't refer them, not just the family, because that's part of the deal we have, that we're providing limited genetic counselling to facilitate timeliness of the testing, and also to take, to help our genetic colleagues with, decrease their workload. But where we identify a variant in someone's germline, that individual quite rightly should go and have more detailed counselling about the implications for them and obviously for their family, as we've said, with the cascade testing. So
good. And I think, Paul, what you said is absolutely right. There is not just the implication, about the ovarian cancer, for example, but as we said, someone with a BRCA1 or BRCA2 gene variant has a higher chance of breast cancer. So there's all the discussion about managing that increased chance.
Prostate cancer for BRCA2 carriers, yes.
We've had a great question, Heather, actually. So question is, could I clarify that HRD and germline testing should be done concurrently? And if a clinician instead first refers to germline testing and the patient tests BRCA variant positive, HRD testing is redundant. So that's a really good question. So the answer is yes, HRD testing is redundant if we identify germline BRCA. So that's exactly correct. However, in reality, what we want to avoid because we have a limited time frame. So if somebody has either a germline variant in BRCA1 or 2, or has a tumour that is HR deficient, we want to be sure that we know that in time to be able to recommend starting on a PARP inhibitor. And the sort of time frame we're talking about, round about 6 to 8 weeks after completing chemotherapy. So we have roughly about 4 months from diagnosis before that decision needs to be taken. And so there has actually been some research on this in the UK, and it's what we based our current Australian guidelines on. So if we just did germline testing, and sometimes that testing is not discussed with people right at diagnosis, because immediately at diagnosis, obviously people have a lot of information they have to absorb. It may not be the right time to talk about mainstreaming and genetic testing. So if that discussion isn't had, let's say, for a month or two, and then someone's begun treatment, and then it may take 6 weeks to get the result, we may not have the result back in time. If the result comes back as no variant identified, in other words, what we've called it's a negative test. I know Cathy doesn't like that term, but no pathogenic variant identified. We've then got to do the HRD testing on the tumour and BRCA testing for somatic BRCA in the tumour. And so it's possible that we may run out of time and not have that result back in time to actually commence the PARP inhibitor. So that's really why we recommend concurrent testing. It's really just a practical thing so that we've got the information. If the germline is negative, we have the tissue information. In some settings, practice did vary around the country, and probably still does a little bit, that tumour testing, what was done first. And if the tumour test didn't show HRD, the assumption was there'd be no germline, but that's the test is not perfect. And one thing I didn't talk about in my slides is that, unfortunately, high-grade serous ovarian and fallopian tube and peritoneal cancer is incredibly heterogeneous. So because it's genomically unstable, you get vast variation. If you sample or take a biopsy 5 millimeters from one piece of the tumor and 5 millimeters in another, you may actually get a different result, which is why the Ovarian Cancer Australia guideline ideally says we should have 4 biopsies from different places, so that you don't run the risk of having one biopsy which says, oh, it's HR proficient, there's no HRD, but actually more of the tumor is HR deficient, you just haven't biopsied the right place. So, ideally concurrent testing should be done. So I hope that answers the question. I think we've had another question.
Oh, yeah.
You're welcome. Just a comment.
A nice thank you.
Is there another question?
No, there was a thank you for the answer to the last one.
Yeah, good. So Robyn, what are linked to this theme, your community at Pink Hope? What sort of services and support are you or hoping to provide to the Pink Hope community?
Mm-hmm. You guys have touched on a little bit of it and have basically alluded to that, you know, people that carry the germline gene mutation have higher risks of breast, ovarian, prostate, and a little bit in the pancreatic space. So, yeah, at Pink Hope, we basically want to support people to make informed decisions about managing their cancer risk. So we very much know that people will make different decisions and, you know, have different situations, and that's absolutely fine. We just want to make sure that people are educated and informed about how they can make those decisions. So, yeah, I think you will well know, Heather, that we have information and support days each year in different states and territories across Australia. We have community catch-ups where we provide sort of online, peer support, face-to-face peer support. We have a great resource library and online resource library, and at the end of, in the next coming months, we're sort of looking at launching a formal peer support program. So, yeah, lots to offer. And we have a really great engaged community in our online support groups. You know, there's over 2,600 women in these groups who, yeah, basically share experiences just like Upinder did, and you know, we learn from each other.
Good. Look, I think the support and advice you give is invaluable. I mean, for most people, the journey and the contacts they make all fall into place, but unfortunately there is that small percentage of people, through no fault of their own, just find it very difficult to navigate the health system. You know, you just need the wrong person once at the end of the phone to find yourself quite lost. So I think that's where Pink Hope really can provide help and support as well, in just putting people back on the right track.
And I think we know what we do complements what happens in, you know, Cathy and Paul's clinical setting. So sometimes when people walk out of Cathy's door, they go, oh, geez, it's going to take me 6 weeks to get my results. Where do I go? And where do I find my tribe? And then they find us. So
good.
That's where we fit in.
Good. Robyn, is there anything else you'd like to comment about today?
No, I think you guys have done an amazing job. You know, everyone will be able to watch this again in slow time and maybe go back to some of those slides and those words that were a bit tricky on a, you know, late on a Tuesday night. So I want to thank you all for your time. I want to thank our supporters, GSK and AstraZeneca, for, you know, supporting us to be able to put this on. And we'll follow up with an email, probably have a little survey and find out, you know, if you found this valuable. But yeah, thank you for attending, and thanks to you guys for making it happen.
Our pleasure.
Yeah,
Thank you for having us. Yeah.
Thank you. Thanks to Pink Hope for everything that you do.
Our pleasure. Night.
Good night.